The time is 10 a.m. Eastern. We'll go ahead and get started. Good morning and good afternoon, and welcome to today's webinar, which is hosted by the Hepatitis Delta Connect program. My name is Stella Dlamini, and I'm a public health program manager at the Hepatitis B Foundation. And I also manage our Hepatitis Delta Connect program. So thank you all for joining us today. Before I go ahead and introduce our speakers, just a few housekeeping items. So all attendees today will be on mute, but we do encourage you to use the chat to let us know who you are and where you're joining from. And if you have any technical issues, please let us know and we can try and resolve that. We also encourage you to use our Q&A box. So we have a Q&A chat where you can drop your questions as you listen to the presentations, and our speakers will address that. And just so you know, today's session is being recorded and this will be shared after the webinar. I also just wanted to take a moment to introduce our Hepatitis Delta Connect program for anyone that is not familiar. So the Hepatitis Delta Connect program is a special program of the Hepatitis B Foundation. It was established in 2016. And the aim of this program really is to raise awareness about hepatitis delta and to promote diagnosis, screening, research, as well as treatment information dissemination for people that either live with hepatitis delta or those that are affected by hepatitis delta. So our program has various initiatives, including newsletters that are relevant to both providers as well as patients. And we also have a website which has a lot of rich information about hepatitis delta. And in addition, we also run events such as webinars like this one and public health research initiatives. And we're always looking to expand our program, and please do look out for us, and we'll keep you informed about opportunities in which you can, which you can get involved. So for today, we're very excited to introduce our speakers for the webinar. We'll first hear from Professor Francesco Negro, who is joining us from Geneva. Professor Negro was previously at the Departments of Medicine as well as the Department of Pathology and Immunology with the University of Geneva. He is also in the governing board of the European Association of the Study of the Liver, or EASL, as well as other viral hepatitis boards, including, of course, being part of the team that developed the 2024 WHO guidelines. So we're excited to hear from Professor Negro shortly. We're also joined by two of our Hep B storytellers, so our patient advocates for hepatitis delta, Rav and Dan, who will also share some of their insights. So without further ado, I will pass it over to Professor Negro to start his presentation.
Okay, I just want to make sure that you can see my screen in full.
Yes, we can.
I would like
see
to
a
thank,
screen. Yeah.
Great, wonderful.
Now
I would like to thank
the
Hepatitis B Foundation, and you in particular, Ms. Damini, for organizing this webinar. Extremely happy to share my experience, my point of view, my horizon, we would say, to Patients Foundation. Extremely important with the, as you know, we share our horizons to get to proper policy, especially. That's why we are discussing this today. And I'm also glad about the choice of the title, because we were also personally involved in this decision of the WHO through my fellow, Dr. Al-Fayyate, and I will explain you in a minute why. This is the plan of my talk. I will just give you a very brief introduction. I believe hepatitis delta virus is not unknown to most of you. We provide some data about the natural course of chronic hepatitis D, and especially how did we come to this decision regarding the increased risk of hepatocellular carcinoma. Is a Delta virus really a carcinogen or not? And most importantly, I will discuss with you what are the implications for liver cancer prevention in terms of diagnosis, in terms of treatment, in terms of surveillance. So just to introduce very briefly, I believe, again, I know most of these things. Hepatitis D, or Delta virus, as it was originally named by the discoverer, Professor Mario Rizzetto in Torino, is the smallest virus infecting mammals. RNA genome, very heterogeneous, we detected by PCR. Importantly, it uses the hepatitis B virus envelope of the co-infecting virus for assembly of the viral particles and entry into hepatocytes. So as a result of this, it's very important, all patients are always dually infected. They always have B and Delta at the same time. Hepatitis Delta virus affects probably about 5% of the HBV carriers worldwide. It follows mostly the way of hepatitis B is also transmitted by essentially the parental route of infection, because mother to child is very rare and sexually is not so frequent. It's possible, but not so frequent. It causes the most severe form of chronic viral hepatitis, which we have problems in treating with antivirals available today, but can be prevented by vaccination against hepatitis B. Let's look at a natural course of the chronic hepatitis D. It is the usual course of chronic viral hepatitis. We say the same for hepatitis B and C. You have two possibilities. One is the co-infection in a normal liver, healthy liver. HBV and HDV arrive together, but the progression chronicity in this case is not so frequent. It's probably less than 5%. Very different is the situation when hepatitis Delta virus arrives on a liver which is already infected by B, so in a chronic carrier or chronic hepatitis B. In this case, the progression to chronicity occurs in more than 90% of patients. It's very, very frequent. And that's where the risk of accelerated progression occurs, because if you have hepatitis B, which has a rate of progression, when you get Delta on top of it, the progression accelerates towards cirrhosis and hepatocellular carcinoma. You see here some percentages. We'll come back later on these numbers. There are many factors which may influence the course of Delta hepatitis, not just B, of course, the underlying B infection. If you have high viremia of B, of course, the progression is much faster. There are many data which are current debated, like, for example, the HDV genotype, the HBV genotype. We are not really sure about their influence. Co-infection with HIV is important, with C probably less. Age and male sex, ethnic origin is never been clarified. There are very discordant data on this point. And then, of course, very important are the cofactors par excellence, like diabetes mellitus, obesity, and alcohol drinking. So if we consider hepatitis B, this is certainly the most logical cofactor of progression. And is also the most easily modifiable. So you can give a nucleoside or nucleotide analogs, and you can suppress very effectively the viral load of B. Now, what happens to the progression of viral hepatitis D when you suppress completely B? Well, actually, you can reduce the number of events, liver-related events, like, for example, the incidence of liver cancer, the compensation, and also liver-related death. But it's not entirely suppressed. I mean, people keep progressing, people keep developing decompensated liver disease, developing liver cancer, and unfortunately die of the end-stage liver disease, which implies that B alone does not account of what happens in chronic hepatitis B. D is very important, and this was shown, for example, by this very important cohort study by investigators from Milano, Italy. Is the so-called MIST cohort, M-I-S-T cohort, which was published several years ago by Raffaella Romeo and collaborators. They showed a very important fact, which is that the viral load exert an influence, viral load of Delta virus exert an influence on the progression of the disease. There is a kind of a dose-response effect. And this was a key factor influencing the WHO decision, which we'll see later on. Now, there are several studies on the progression of chronic hepatitis D. I will not certainly deal with all of them. I just would like to mention one meta-analysis, which is been published recently, 1 year ago, by the Professor Gish. You know him certainly very well. He's very active in the field. And this study, which collects and analyzes the data from several previous studies, shows very well the risk of progression in those who are still viremic, who have delta viremia, versus those who do not have viremia anymore, or who are never, in fact, progress into chronicity, but they still harbor the antibodies, is increased. It's increased by 2-3 times, especially. If you look at, for example, the progression to the compensated cirrhosis, the risk is almost 4 times compared to those who are delta RNA negative. And you see here any other liver-related events, they are all increased. The risk is increased for all of them. So it's very crucially important and very nicely shown that hepatitis delta virus accelerates the progression of hepatitis B. Well, one of the points that we have to discuss today, but the most important, is the topic of the day, is does HDV increase the risk of hepatocellular carcinoma? We already seen some of this data. We'll go through some of the studies showing that in a very convincing way. One is from the United States, for example, Tina Kushner. She showed this about 10 years ago. She used a huge cohort of patients from the Veterans Administration, showing that the adjusted odds ratio of developing liver cancer is the double when you have delta superinfection. Many other predictors of HCC, or liver cancer, older age, alcohol use, cirrhosis. Let's not forget that this population is heavily affected by many cofactors of, unfortunately, of liver disease progression. Also, it's essentially formed by male, okay, but understand, but this risk applies to the whole delta population. If this was shown very nicely, if it's a French study, I just want to show and mention this French study because it's based on 2 very well characterized cohorts. One is a prospective cohort from NRS, the CIRVIR, the very, very famous cohort, and a retrospective delta VIR cohorts. Big numbers again, and you show that you have the incidence of liver cancer is increasing over time dramatically in those who are co-infected with delta. Actually, the risk is about 5 times. It's very, very much increased. The number of studies is huge in the field, and to the point that now there are several meta-analyses showing that. The quality of the previous studies was not always very good. For example, in this study, which was provided, was the first meta-analysis provided by my group in Geneva. If you look at the overall studies, 93 studies overall, the risk seemed increased, but not so significantly. It's about 30%. But the issue changes dramatically if you only consider those studies with very good quality collection of data. For example, the prospective studies, only 11 were available. You see here the risk of developing cancer is almost 3-fold compared to those who have B hepatitis alone. And these data were replicated by at least 2 other meta-analyses. One is from the Karolinska Institute from Stockholm in Sweden. You see again that the risk is about twice as compared to what we see in hepatitis B alone. Also in those who have a cirrhosis, very nicely shown by little number of studies, but still very, very significant, and also independent of the ethnicity of the population being studied. So which means that it's not something which has to do essentially with the virus. And again, this study also from Taiwan replicated the same results, using the same kind of analysis. The risk was 2-fold compared to hepatitis B alone. So looking at all these numerous pieces of evidence, WHO at the beginning of this year, 25, collected a panel of experts, and my fellow who published the first meta-analysis, Dr. Al-Fayyad, was a member of this panel, to discuss how to consider hepatitis delta virus. The panel did another meta-analysis, a 4th, relative risk is at 2.13 in this case, which actually means, again, the hepatitis delta virus doubles the risk of developing cancer compared to hepatitis B. Not only, again, they quoted this a very important study from Raffaella Romeo. I just mentioned that before. There was a dose-response relationship with liver cancer. The higher the viral load, the higher the risk of developing liver cancer. So the panel concluded that the mechanistic evidence for hepatitis delta virus was very strong for the key characteristics of carcinogens. There was no doubt to classify this virus as a group 1 carcinogen. And group 1 means there is definitive evidence in humans. There is no question about this. Now, Hepatitis delta virus is considered a class 1 carcinogen together with hepatitis B virus and hepatitis C virus. So these two viruses were considered carcinogenic in 2009, and finally also hepatitis delta virus is considered a carcinogenic virus without questions. And this is very important because we certainly, foster not only awareness. And awareness is always very important, especially among policymakers and lay people, because this may influence decisions at the public health level. But also important because we certainly foster investment from the industry, from other foundations also, why not, and the associations, which may promote research in the field of viral hepatitis D. So I think this step was extremely important as a watershed decision this year. What are the implications? So let's start with the diagnosis. So diagnosis of hepatitis delta is extremely simple because you only have to test for a global antibody and confirm the replication of the virus by testing by PCR, RT-PCR, the presence of the virus in serum. Considering, this is a very important step, considering that 40% of those who have the antibodies have only antibody, they have cleared the virus at the time of infection. A corollary of this diagnosis algorithm, don't forget, hepatitis delta virus interferes with HBV replication. So HBV DNA, usually by rule, is low or undetectable, and E antigen mostly absent. So when you see an hepatitis B with increased liver enzymes, elevated transaminases, but very low HBV DNA, this should alert you that there may be a cofactor, and one of these cofactors very often is hepatitis delta superinfection. So whom to test for hepatitis D? That's where the discussion is still ongoing, because international societies, including WHO, have a very different approaches to the screening strategy. The American Association for the Study of Liver Disease, there is a guidance published in 2018. They suggest to test for delta only those with a B, of course, and elevated transaminases or risk factors in those who have cirrhosis, in the hepatocellular carcinoma, of course. The risk factors are being born in high endemicity countries, people who have ever injected drugs, men who have sex with men, people infected with HCV or HIV because they share the modality of infection, people with multiple sex partners or history of sexually transmitted infections, patients with elevated liver enzymes, and low or undetectable HBV DNA due to this very famous suppressive effect of the virus on B. And you see, for example, the European societies have started in our guidelines to test everybody, at least everybody, at least once in a lifetime. I think that's suggested by some studies I will show you in a moment. WHO is also very conscious about the problem. In principle, WHO suggests to test everybody with the aim to scale up access to diagnosis and linkage to care, and restrict to risk groups only if assays are poorly available and also if there are not many other possibilities. We must consider WHO is very much focusing on resource-poor countries, and where maybe even testing for RNA may be impossible or very, very difficult. Just to remind you, the risk factors is also being born in countries with high endemicity, and you see here in red those which are considered high endemicity with very high level of prevalence of Delta virus, super important B, for example. Mongolia is the highest in the world, some areas of Pakistan, Romania, and Moldova in Europe, some countries in Africa, from the West Africa, but also Somalia, and some areas in the Southern America. So people who migrate to low prevalence countries, but they come from high endemicity countries, should not lose the right to be tested, because they would have the right to be tested in their own country. They come into a very low prevalence country does not mean to lose the right to be tested and, of course, linked to care and treated. So are the screening strategies so far used adequate? Is what we do, is it enough? Is good or not? Well, if you look at the data, even in some countries where there is a big awareness, where the virus was studied since the very beginning, like Greece and Spain, only a minority of patients with B are tested also for that. Maybe doctors test only those at high risk. So these data by themselves do not tell us if the job is properly done. But if you look, for example, at what happens in Hong Kong, I find it very hard to believe that less than 1% proportion of patients being tested for Delta is a good approach to the problem. Well, I mean, the issue was clarified by countries, by studies where investigators started testing everybody. And the first study to do this automatic testing for all B was done in Spain. Spain is known for having provided a lot of important studies on hepatitis D. And this study was from the group of Maria Buti in Barcelona. So in the past, they were testing only a minority. You see here on the left-hand side of the columns, only a few patients were identified. But when the investigators started testing everybody, the number of diagnoses increased by 5 times. And not only that, I mean, they were identifying more patients, but not only that. The point is that, I mean, 60% of these people newly diagnosed had no known risk factors. And 1/3 of them had the liver cirrhosis, which implies that testing only based on risk factors is not enough. We should actually probably test everybody, at least in European studies. I mean, we have at least 2 other major studies confirming the evidence provided by the Dr. Palom and Maria Buti, one from Vienna, the other one from France, showing that if you implement a reflex assay, an automatic testing for everybody, you increase the number of diagnoses of Delta patients. Of course, does it cost a lot of money? Yeah, maybe yes, but it is cost effective. And this is actually a study from United States, from your country. You see here, I mean, even if you treat only a few of them, I mean, you would certainly avoid a lot of cases of cirrhosis, liver cancer, and hepatitis Delta related deaths. Even screening for everybody will cost you, I mean, this number probably does not tell you a lot about the incremental cost effectiveness ratio per quality adjusted life here. $22,000 per patients found. I mean, that's very important, but you have to test everybody, and you would avert these numbers of liver-related events per 100,000 surface antigen positive individual screened. It is cost-effective because the ICER, this formula, magic formula, falls below the so-called threshold for willingness to pay. I'm sorry to be very technical, but if you look at just the numbers, it is certainly cost-effective. So it would be worthwhile to extend the screening strategy to everybody, at least once in a lifetime. But of course, the decision in public health, you know, is not just based on science, and they're based on politics, on political priorities, and I will not go into much detail of this, you know very well. I mean, playing in favor of universal screening, well, the fact that it's cost-effective, but the cost-effective means a model. A model does not mean empirical data. Also, because I showed you that risk-based strategies of screening may miss a significant number of Delta-infected patients. This was very nicely shown in Europe, many studies from our countries. Also, because people sometimes do not like to share stigmatizing behaviors. So the problem is that people don't say, I'm a person at risk, and so we will not to get tested. It's a problem. I think we are missing certain people because of that problem. Tests are very simple, by the way, and they can be easily integrated under screening strategies. Just a blood test. It costs very little, by the way. But playing against universal screening, there are many other considerations. First of all, it is sensitive to prevalence. Cost of diagnostics is not important in rich countries. It is a very important problem in many poor countries, unfortunately. It depends also on the cost of antivirals, availability of antivirals, and the treatment uptake. So we must have a linkage to care, which is worked very well. Politicians are also sometimes very sensitive to this discounting bias, and they have to plan a budget, very strong, important budget immediately, but nobody really knows whether this will provide benefits in the very distant future. There are many unaccounted costs in these evaluations. You must run an awareness campaign, you have to inform general practitioners to do the test, why they should do the test, what to do in case of positivity. I mean, this costs money, of course. And also in very low risk population segments, there is a rule, unfortunately, the yield of the testing is very inefficient, which means that you must calculate what is the number to be tested to have one positive. And sometimes this number is too high to justify universal screening. So these are the considerations, of course, when the decision is up to politicians to be made. Implication for therapy, of course, you certainly know that what has been used for, I would certainly say at least 30 years probably, is a pegylated, initially was a standard interferon, but now is used pegylated interferon alpha 2A initially from Roche, but it's not being approved for delta. The funny thing is that it has been approved for hepatitis B, but since all delta patients also have B, we can justify the use of pegylated interferon alpha. And alpha 2B is no longer available now. There is a new formulation, but not for hepatitis delta. Pegylated interferon alpha is given in general for 48 weeks. This length of treatment is based empirically on what we used to do for hepatitis B. Some authors have suggested prolonged therapy. I remember in the United States also with J. Negro, we were discussing this many years ago, or repeated courses, which is an attitude which is used by many Turkish specialists. And the virologic endpoints ideally should be the loss of surface antigen, which is almost never reached. The acceptable is the clearance of delta RNA 24 weeks after the end of therapy. And this is the recommendation, European recommendation, where I participated personally to contribute to these recommendations. Whom should we treat? Well, I would say that all patients with hepatitis D should be considered for antiviral treatment. Of course, the decision remains a negotiation with the patient will and availability, etc. Those with decompensated cirrhosis cannot be treated with interferon. They should be evaluated for liver transplantation. And those with cancer should be considered with antiviral treatment depending on individual basis. For example, if curative treatments for cancer are available. The American Association for Study Abilities guidance also says the same thing, but adds also a very important point, which is do not forget about hepatitis B, because you should not forget, especially because if the delta, if the B DNA is elevated, you must treat for B. Of course, there are the same guidelines we did for hepatitis B. And also it's very important to consider that when you suppress delta, you will suppress the suppressive action of delta on B. So you may have some reactivations during treatment. It's very important to know this. Does interferon work? Well, it does work, but we are not very happy about the results because the cost is important in terms of, unfortunately, side effects for patients. It's not very well tolerated. And at the very end of the day, you cure about 30% of patients in the best case scenario. So one patient will be cured, including sometimes a cirrhotic patient. I have a very good experience with that. Clearance of delta RNA is not reached all the time, 30% of patients, but it is associated with an improved outcome. Is associated definitely with improved survival. So that's what we should reach in terms of endpoint when you treat with interferon. Well, since interferon is not the panacea, it's not the best treatment available, of course, we have to look at the future. And in some countries, the future is already there because lipopeptide, the bulevirtide has been approved, especially in Europe, but also in Switzerland, many other countries, I believe in South Korea, and many other countries. And we'll see in a moment how it works. There are many other molecules which are being tested now, and it's very important that we get solid results in the long range. Until now, we only have data on treatment, which seems very promising, but we don't have end of follow-up results. But it seems a very promising pipeline. Most drugs are targeting the interaction between the virus and its receptor, and we'll see it now with the bulevirtide. Now, let me add one detail which is very important to know. There was a white paper years ago, and the FDA made it proper. We don't consider clearance of the viral RNA anymore alone. We also consider the 2-log decline of serum HTV RNA as an acceptable endpoint. And this has been imposed also on all clinical trials. It is also considered as a favorable endpoint when it comes to clinical outcomes. And this was based, it must be said, based on one single study done on a very limited number of patients to do with the interferon many, many years ago. But it's still considered valid in all clinical trials now, and also in evaluating the efficacy in the long range. How does bulevirtide work? I know you don't have it in the United States, but I believe the application to the FDA has been resubmitted and probably will be, I hope, for you accepted. It is acting at the level of interaction between the surface antigen at the surface of the HDV virion, the viral particle, and interaction with its proper receptor. The receptor has this complicated name, sodium taurocholate cotransporter polypeptide, which is also the receptor for biliary acids. So in a way, when the virus interacts, or bulevirtide interacts with the receptor, there is a inhibition of the uptake of biliary salts by the hepatocyte, but this does not seem to have important clinical consequences. So that's how bulevirtide works. So it inhibits the entry of the virus into the liver cells. And I will show you just very briefly some results of the phase 3 study of bulevirtide. Most of this data have been already published in the New England Journal of Medicine. Heiner Wedemeyer published the latest data at the as abstract in abstract form on the proceedings of the European Association of Study of Liver meeting this year. You see, if you look at the follow-up 96, which means 2 years after the end of treatment, treatment lasted for 3 years, 24% of patients had a combined response, which means clearance of the virus, 2-log decline, plus normal liver enzymes. And the virologic response was 33%. Again, this is the global virologic response, clearance of the virus plus 2-log decline of the viral load. If you look only at the clearance of the virus, which makes it more comparable to what we see with interferon, is 20%. It's not bad. It's not probably the best that we can opt, of course, but it means that with a monotherapy, bulevirtide, simple injections, pretty well tolerated, I would say, you can eliminate the virus in 1 patient out of 5. It's not the optimum, I agree, but can be done. What is interesting is to answer the question, does treatment, even for many years, with bulevirtide decrease the risk of liver cancer? We don't really have yet the final answer to this crucial question. We know that after 2 years of treatment, for example, in this safety retrospective study, the cumulative risk of liver cancer was 3% in 2 years. It's 1.5% per year. It's pretty low compared to what you see in untreated patients. So maybe there is a suggestive data that the liver cancer the risk may be reduced by bulevirtide alone. What is even more interesting is that the very preliminary data of the use off-label use of bulevirtide, because I insist it's not approved in Europe for use in the compensated liver disease, in some patients who were in the waiting list for liver transplantation. This is a multi-center retrospective French study. You see here 7 patients were in the list treated with bulevirtide, and some of them were even delisted when bulevirtide was applied, which means the liver function improved dramatically. And this is very, very hopeful message for the user. It's still not tested in this setting. There are no clinical trials to best my knowledge, only off-label use so far, but they should probably be considered in some specific cases. What about the interferon association with the bulevirtide? That's very interesting because there are some data from this study, for example, published by Tariq Asselai in New England Journal of Medicine last year. You see here the end of follow-up clearance of the virus. This is not the composite endpoint, 2-log plus clearance of the virus, just absolutely just clearance of the virus, 26%. Again, it's not the best we can expect, of course, but it's still somehow better than probably bulevirtide alone. I mean, you see here the comparison is not really good, but if you look at the data we just showed from the phase 3 study, 20% bulevirtide, 26% if you combine with interferon. Bulevirtide 10 milligrams would be better, but the 10 milligram is not in the label, so it cannot be used in any countries in the world. If you just summarize what is the comparison which can be made between pegylated interferon alpha and bulevirtide, you see here administration pegylated interferon alpha, you know very well, is subcutaneous once a week with a pre-filled syringe. Bulevirtide have to be reconstituted every day and is injected every day subcutaneously. Duration of therapy for interferon is 48 weeks standard. For bulevirtide is undefined. The phase 3 study used it for 3 years. Efficacy, I mean, undetectable RNA at the end of follow-up, 29% in average for pegylated interferon alpha, 20% bulevirtide. Safety, well, unfortunately, interferon is not very easy to handle, requires experience, has a very potentially severe side effects. Bulevirtide is very well tolerated. Just be careful when you stop it. You may have very rare cases, hepatitis flares. Clinical outcomes, the effect on outcome is improved survival with interferon, is very, very nicely proven, provided that you clear the virus. For bulevirtide, we know there is a decreased portal hypertension. It's not bad, actually very important. And some preliminary data on liver function and liver cancer suggested that it may actually improve the function. So what to use? Well, the European Association for Study of Liver recommendation as shown in this slide, this diagram, for very early stages of fibrosis, finite treatment is better. Pegylated interferon alpha monotherapy or associated bulevirtide, depending on availability. For late stages of disease, but not compensated, unfortunately, we cannot use it off-label in these cases. Probably bulevirtide alone is the best option. Implications, finally, for surveillance. I mean, it's very important that given the risk of liver cancer, all patients with cirrhosis be surveilled for liver cancer. We must undergo, this very clearly stated in American guidelines, they must undergo ultrasound echography every 6 months, plus or minus alpha-fetoprotein dosage. There's no question about this. And also the European recommendation, they say the same. It may also be reasonable to extend the surveillance program also to those who do not have clearly cirrhosis, just the F3, with according to Metavir stage, what we call bridging fibrosis, especially in presence of other liver cancer risk factors, for example, alcohol use, tobacco, obesity, family history of liver cancer, exposure to aflatoxins for patients coming from certain countries in Africa, and the co-infection with HIV and HCV. So my take-home messages, and I will conclude here, is the following. The hepatitis delta virus infection is certainly associated with an increased risk of liver cancer, at least a twofold minimum. You must please get tested for delta virus. If you are positive, please consult your medical doctor for any kind of counseling regarding transmission, treatment, and surveillance. And also, why not get information about clinical trials in your area. And with that, I would like to thank you for your attention, and I'm ready to take any question from you.
Thank you so much, Professor Negro, for that very rich and informative presentation. I do encourage anyone with questions to put their questions in the Q&A box. But I will also just start off with my own questions. So I think we've clearly seen the data about like the much increased risk of HCC from HDV. And I know that you've also presented some of the factors playing against testing all people who are surface antigen positive. But do you think with this data and the reclassification of Delta as carcinogenic, there should be a change in prioritization of HDV testing, especially among people that have chronic HBV?
Well, this is my hope, clearly. I'm a strong supporter of this. But be careful because, I mean, the screening is important, but has to be associated with a very good awareness and education among the medical doctors, of course, practitioners, and the patients. But what does it imply after? Once you are tested and tested positive, what do you do? So, I mean, one of the advice I gave here is just to consult with major liver centers to see if any clinical trial is ongoing, because that's a very good opportunity to undergo. I know not all doctors, unfortunately, have a good experience with pegylated interferon alpha. Which implies that it's not so easy. Maybe I believe some doctor may even be reluctant to test for that reason. But you know, there are so many good specialists. I mean, we've been learning so many things with hepatitis B and hepatitis C. Also, how to use interferon properly. I don't really, I mean, I think it should be a problem to refer patients to a liver center and to get properly managed. So insist on the testing first and proper linkage to care. I see, I mean, there are some questions in the chat.
We have some more questions in the chat. So
liver stiffness, yes, liver stiffness, but absolutely, it will certainly improve because The first reason why liver stiffness improves when you get treated is the decrease of inflammation. So it's not necessarily the decrease of fibrosis. It takes time, it takes a long time before fibrosis disappears. So if you get the liver stiffness going down, is first of all the decrease of inflammation. The second point is very likely decrease in portal hypertension, which has been proven, for example, for bulevirtide. We've seen that with clinically significant portal hypertension. There is a very nice study from a group of Pietro Lampertico showing that there is an improvement. So yes, I do expect during treatment a decrease in liver stiffness, but please don't focus on this, because what really matters is the liver function. This is what is very important. And so if you have, for example, for child A6, because the prothrombin time is slightly decreased, I mean, that's increasing, the time is increased, of the percentage is decreased. Of course, in these cases, it's very important that the liver function improves and the liver enzymes decrease, and there is no longer inflammation, and so the fibrosis will not progress. So liver stiffness is important. Just one single parameter is not enough to cry victory. It's very, very important, but it's not enough.
Yep, and we do have another question.
Yeah.
Is there any need to follow
No, you don't.
After starting bulevirtide?
No, you don't really follow it. You may check if there is a itching important prurite, but it's self-limited and it's not been associated with the important consequences. So don't worry about this.
Okay, thank you.
Okay.
I think we have one final question.
I'm glad to see that people from many far countries, very far.
Is there an explanation for the low HBV replication during co-infection with hepatitis delta? And does this have an underestimated consequence?
Unfortunately, we don't know why delta inhibits B. That's a big question. I was actually involved in the studies when I was at NIH, but we could never really understand why there is a cis suppression. We may just, I mean, very naively say, it's just a typical viral interference, because we see that for hepatitis C, for example. When you have a triple infection, what you typically see, the hepatitis C virus is almost completely suppressed. So it's probably not a specific effect, but it's probably a non-specific effect of a very strong inducer of interferon against other viruses. That's the most simple explanation. But there may be actually more specific explanations in the specific cytokine profile, action effects on the production of the viral proteins of B by the delta, which I will not speculate about. If you want a simple answer to this question, it is very non-specific interfering effect by co-infection on the weakest viruses. Okay, the delta is the strongest and the C and B are the weakest.
Perfect. Thank you so much. I would like to now introduce Rav and Dan, who are our Hep B storytellers, to introduce themselves. And if you have any comments from Professor Negro's presentation, please go ahead. So Rav, if you don't mind introducing yourself and any comments.
Hello, everyone. Thank you, Professor Negro, for a wonderful presentation. As I said in my comments, you answered a lot of questions that I had as you were presenting. My name is Ravshan Yakubov. I'm born and raised in Uzbekistan, so one of the Central Asian countries. That's where most of the Delta is prevalent, as we know now. Back in the 80s, that was obviously something new, and we didn't learn about it until late. I'm currently in Ottawa, in Canada. I immigrated from US, where I was a student, to Canada. I always knew that I had hepatitis B. I was infected as a child at the age of 2 with a dirty needle. the routine vaccination was for something else, and they used dirty needle, and that's how I got hepatitis. Most likely, now I know, most likely it was super infection because I was sick acutely at the age of 2, 4, and 6. And at the age of 6, I was formally diagnosed with a chronic hepatitis B. And since then, I was always on some sort of diets, and I didn't participate in any sports activities, nothing heavy to be lifted, and all of the other things that we thought back in the day was important for chronic hepatitis B patients. So fast forward to 2013 when I immigrated to Canada and met with my first family physician at a routine check. I just mentioned that I'm chronic hepatitis B carrier, and that prompted her to do all of the follow-ups. So my family physician at the family clinic knew the protocol, and I'm very happy that she did what she did for me. So she referred me to a hepatologist. She did order MRI and blood work, and obviously that's how we learned that I also have hepatitis delta, which was complete news to me. I didn't even know that it existed. I always thought I'm well educated and knowledgeable about hepatitis B, and again, didn't know anything about delta, right? So that kind of shows you that even if a patient knows about the condition, about hepatitis B, and strives to get information about it, and you can have the blind spot. And for me, it was hepatitis delta. So it was kind of, back in 2013, it was bad and good news when I was, met with a hepatologist. So the good news is that I don't have liver cancer, but the bad news is that I have hepatitis delta and cirrhosis. So I was told at that time. So I learned that it was a very difficult time for me to get the diagnosis because I was, a new dad. I had my first daughter, was 5 months old. We just bought a new house. We didn't get possession yet, but we signed the papers, and I was about to move into the new house. And I was going through the professional, exams, very important CPA exams, and that was kind of, my world was crashing around me. So, but I was determined, obviously, to get through this, and all of my follow-ups with hepatologists since 2013 were, it was just a 6 months meeting, blood work. Somehow, magically, my blood sample for delta testing was consistently missed. I learned the reason why later, but it's it's a combination of just a human error and the system limitation, where when they go and select the blood work in the new program, in the new software, they use Epic. It's not right there for them to select. They need to go and dig for an unusual, rare, blood work that they need to do, and unfortunately, not a lot of doctors knew about it, so they would just scribble something on a piece of paper, and the lab didn't compare, the request on the computer with the request on paper, and that's how I was basically missing the information. So for 10 years, I knew about the interferon. 2013, the doctor casually mentioned, yeah, there is an interferon, efficacy is very low, you're most likely not going to be a good candidate for it, and I don't want to treat you with that. And it wasn't until 2023 where, my new doctor now said something like, you're not getting any younger, you're over 40 now, I'm not comfortable doing nothing at this point, so let's try interferon. And we tried interferon in May of 2023. I did my first storytelling event with the Hepatitis B Foundation at that year, that summer, and when I was 5-6 weeks into interferon, and that was I wasn't myself. So interferon did have a lot of negative impacts. All the documented side effects, I had them, and but it did help me to get to undetectable delta levels within the first couple months. I persevered and kept on it for 48 weeks just to make sure that I did my part, right? That I did everything that I could to get rid of this. So 48 weeks, platelets as low as 11. I had severe bleeding, and my doctor, even at the week of 36, 34, said, we can pull a plug and most likely we need, and if you proceed, it's going to be on you. But I did anyway. So I got rid of it. And for 2 years, I was clear. It wasn't until September of this year where I learned that, September was my meeting. I got the blood work and the results came in October that Delta is detectable again, right? So now my journey with hepatitis Delta continues, and I'm more than determined to get rid of it now. But now in Canada, bulevirtide is available. So I'm literally one of the first patients in Canada to get it. We finalized the last pieces of paperwork yesterday with Gilead and with my doctor, and my doctor is amazing. He's pushing it for me. We got through the training yesterday with the nurses, and I'm getting the drug today, and I will be taking it at some point this week. So very pumped. Interferon, with all of these its limitations, did help me. I believe that bought me an additional 2 years while we were waiting for bulevirtide to be available, and I'm very happy that now I can try bulevirtide. And obviously, my questions to you, Dr. Negro, was because of that. I know not to focus only on liver stiffness, but it's something that is always in the back of my mind. Is when I go and meet with the physician, it's always that picture of liver stages F1 to F4, and the next one is being liver cancer. It's not giving me kind of warm and fuzzy feelings every time I go to the office. It's like I want to just put my jacket over that so I'm not reading too much into it. But this is basically kind of like my quick story, and I'm very excited that the now hepatitis Delta is being formally recognized as carcinogenic, because it's obviously I hope that it will lead to more research, more funding into not just drugs, but overall awareness raising. And I'm continuing my advocacy work despite everything, because I feel that it's very important that not only the population but also healthcare providers know that having Delta disease in combination with B is very, it's most likely not as rare as they think. It's just because people are not being tested, and the standards are different in different countries, as you presented. We're trying also through Action Hepatitis Canada to make sure that all adults are treated at least once, to make that policy, and to make sure that there is more funding and into the healthcare provider research and education. So again, I already talked about the awareness and the reason why I'm doing it. This is something that I'm living with most of my life, and sometimes when I'm getting questions like, okay, how did you learn about hepatitis B, and how did you feel, how it would change your life? I say, well, I lived with it for more than 40 years, and I don't know what the normal is, right? So for me, normal is to go every 6 months and meet with my physicians, and I'm able and willing to do it. Some people may not be, but I strongly believe that just because I am doing it, I'm still around, right? That's the best I can do. Then the more I learn about it, the most scared I am, but then I'm also happy that I can raise awareness, and I do talk a lot in my community about the risks. And as I learned now that Mongolia, Central Asia specifically, and being close to Afghanistan, that's where almost like one of the epicenters of Delta is. And sometimes I'm very surprised and kind of a little bit angry that developed world like Canada, it's such a big issue to get something that you think as a patient it should be easier. It takes me a month to get Delta virus blood work back. Only twice since I was diagnosed back in 2013, I learned my viral load. So it always comes back as detectable, undetectable. It was only right before the interferon treatment in May of 2023 when my doctor made several, asks and went well beyond his responsibility to get the viral load from Winnipeg. It's not even tested in Ontario, in my province. And then on top of that, like another 2 years, it's only until now, and I'm being a guinea pig for bulevirtide, and they're not hiding it. The whole hepatitis B and D medical crew came out yesterday to meet with me when I was meeting with my doctor to see, oh, well, you're the one who's getting bulevirtide. It's going to be a first one in Ottawa for sure. I got the viral load for this time as well, just to set the basis and to put it into, my file that, okay, well, this is how we're starting and let's see what happens. That's another big problem that I'm trying to change through my advocacy work in Canada, that simple thing as the blood work shouldn't take months, and it shouldn't come back as detectable, undetectable. It should be capacities, funding should be available in every province, and you shouldn't send the blood work across the province lines and wait until cows come home to get it. So I'll pause just in case if someone has questions, but I think this is my story. But again, very excited about this new classification of hepatitis delta. Hopefully, it will help to move this forward.
Thank you. Can I make some comments?
Yes, please go ahead.
I can't hear you guys.
Can you hear me?
Maybe it's me.
Can you
hear me?
Oh, now I can. Yes.
Okay.
Now I can.
No, it's a very telling story, very interesting story for many reasons. So, from what I understand, you were born in the 80s, probably in Uzbekistan.
1980.
Okay. I was in Uzbekistan the first time. I've been 7 times to Uzbekistan for collaborations. I mean, in 1999, because the Development and Cooperation Department of the Swiss government was summoned by the authorities in Tashkent to set up a reference lab for viral hepatitis, and I was part of the team. And I know very well the situation in your country, the way it was in '99, because I'm sorry to say they were not even testing for lack of good quality tests. They were not even testing the blood donors, just to let you know. So I understand very well what happened to you and to many other unfortunate poor young Uzbek who were contaminated because of the lack of proper procedure. But there was, I understand, I mean, it was lack of resources, it was the collapse of the Soviet Union, lack of money. The assays were not good quality, were not referenced. Now situation has changed a lot. I was there last time, not long ago, Tashkent again with Professor Musabayev, probably you know him. He actually is the one who set up the reference lab. So this story is actually, I mean, carbon copy. I heard it 1,000 times from your country and many other countries, unfortunately. The second point is you pointed out what is the single most important problem, which is lack of awareness. We have not been discussing enough, probably among lay people, not, I mean, specialists, I have no problem, but I mean, lay people have no idea what the hepatitis, even the viral hepatitis in general, sometimes we associate, well, viral hepatitis is a problem with drug addiction. I mean, that's the point, which is not true, in fact. I mean, your story shows very nicely that you may actually acquire the virus in a iatrogenic. Just going to the hospital where you expect to be protected, you get the virus. I mean, I've received this so many times, even my hospital, for accidents, for so it's not intentional, but I mean, sometimes procedures are not properly done. So, and this lack of awareness is a devastating issue because people not just don't know, they, you know, what unknown I know, they don't know, they don't what they don't know. So, but they don't ask the question. And this is a tragedy for many patients around the world, not just in the field of viral hepatitis. I mean, I'm seeing also for HIV and many other issues. So, I mean, I'm happy that you're getting bulevirtide now. I mean, I will certainly, encourage you to do that. Viral load is important. It's not, a detail. There are some, you were cured for 2 years, from what I understand, right? Clearance? Okay. We know that up to 5 years, there is a small but substantial risk of small relapses. We know that. And there are virological reasons for that, because there are some isolated islands, clusters of liver cells, which are infected only by Delta, probably they are rescued very late by B. If you don't have the two viruses within the same cell, Delta cannot get out. So you don't see the viral load in plasma. This is probably what explains why we sometimes see some blips of the virus later on, even 2, 3, 4 years after the cure. But I mean, viral load is not a detail in your case, because if the viral load is very low now, I don't know how high it is now, but
29 is small. Yeah.
Sorry?
29 international units. I think it's 29. So it's probably
very
just very low. Yeah.
It's very, very low, which actually goes well with the data we have, not very much many data, but the data we know about these relapses, late recurrence, they're usually small blips, because the number of liver cells which are producing the virus is very small. That's essentially the point. And they've been destroyed by interferon in the past, probably. And also probably, I mean, this viral load, which is very low, is associated with improved outcome anyway, whatever you do. But this does not mean that you should not be treated. You must be, please, get treated, get rid of once of all, because from what also I understand, from what the data you share with me, your liver fibrosis is advanced, which implies that, I mean, whatever you can do to eliminate all the risk factors of liver cancer, you must do it. I mean, please don't. I mean, I believe you don't drink alcohol at all. You're not overweight. You don't have diabetes, hopefully. And so, I mean, all these issues are important to get under control. All cofactors might be, as far as you can, be controlled. So, I mean, I encourage you. I'm glad you get to bulevirtide. Go ahead.
Thank you.
Thank you so much, Rav, for sharing your story with us. A lot of people are excited to hear it, and wishing you all the best with the new treatment journey. I'll now like to introduce Dan. Dan, if you could just introduce yourself briefly, and if you have any comments from today's webinar.
Hi, good evening from my side, because in Romania it's already evening. My name is Dan. I come from Bucharest, Romania. I've been living, having this condition of hepatitis B and D since 2014. Thank you very much, Rav, for your story. I identified a lot in it. All the best of luck with the new treatment. I really hope it will work, and it will work for sure. And thank you for inspiring others. I think that's the most important thing, and that's why we're doing this storytelling. In my case, what I can comment, I discovered hepatitis D in 2014 because my partner at the time, he did some tests and discovered the condition. So I said I will do the same test, and then I got the diagnosis. I straight away started with interferon, 48 weeks at the beginning. The viral loads, well, in Romania, it's quite a big thing, so they do it quite often. So it was very, very high in 2014. It was above 100 million, if I remember well, units. And then at the end of those 48 weeks of initial treatment, I got it to around 6,000. But that was it. It didn't get undetected. So then I remember I paused for 1 year, and then I started interferon again. And I think in total, until Hepcludex came to Romania last year, I think I did like maybe 4 rounds of interferon. And at some point, I even did more than 48 weeks. I did 1.5 years. but still, I think the lowest viral load was 5,000 something, 6,000. So it never got undetected. When it comes to fibrosis, I had F2, F3, like the majority of these years, but last year, in March, if I'm not mistaken, from FibroScan, I got the F3 to F4 reading. So the cirrhosis, or close to the cirrhosis diagnosed. Then in July last year, all the bureaucracy finished in Romania, and we got Hepcludex. I know the substance is but I cannot pronounce it, so that's why I always say the commercial name that we have it here in Europe. So I started with Hepcludex and interferon. So my doctor recommended the two therapies. And I started, and until January this year, I did them both. And then all of a sudden, interferon disappeared from Romania, so you cannot find it anymore. So I had to stop the dual therapy. And then things didn't go that well. The last tests, when I was doing both therapies, my ASL, so these transaminases tests were actually normal. And the viral load got me. So when I started with the Hepcludex, it was something like 2 million units, and it was 100,000 in January this year. But then I continued only with Hepcludex, and yeah, the viral load started to raise, and also this ASL and this transaminases started to rise again. Currently, I'm standing around 300 units for the ASL, if I'm not mistaken. But anyway, I'm continuing with the Hepcludex therapy. I still have left. I think more than 6 months, so until July next year. And I'm just hoping for maybe the new therapies to get approved here in Europe and see what can be done. Coming back to personal story, I'm happy I live in the European Union. Actually, it was quite easy for me to always get access to doctors, to get the tests, you know, to have all these actually very expensive blood tests for free. Every 6 months, of course, the tests are more into depth. So like with viral load and extra blood tests that I've done. Also FibroScan, FibroMax, I did also many times. So from this point of view, I'm thankful that you know, everything is provided by the medical system here in Romania. We do have a big problem with bureaucracy. So, for example, to get Hepcludex approved in Romania, it took like maybe 2 years from the moment that the European Union recommended it. But still, you know, it's never too late. I was also one of the first, if not the first patient to start here in Romania with Hepcludex. I know there are a couple of hundreds now in Romania receiving this therapy. In my case, is not doing that well, but I really hope in other cases it's a success. And nothing. I just hope for a better future, you know, like, and for these new therapies that are currently under trials to get you know, final approval, and maybe to start one of that. Until now, it was never discussed with my doctors, you know, for me to be on the transplant list, or to be considered for a transplant. Until now, I feel healthy. Actually, it's not something that's affecting. You know, I can work, I can, you know, spend time with my friends. Of course, I'm not consuming alcohol, and I'm not. I'm behaving. Let's say I'm a good boy. But yeah, I know it's a serious condition, but I'm also very optimistic person. So also me telling my story and discussing with a lot of people around. I just want to give hope that it's not a death sentence, and if with good care, you can live your life, close to normal. Most probably hepatitis B, I have it from birth, because again, it's the same story maybe with Rav. I come from an area where this condition was quite a big thing. We did not have in Romania a national vaccination program until I think it was introduced in 1992. I was born in 1985, so most probably I have this hepatitis B since birth, but the hepatitis D, I discovered it in 2014. That's pretty much about my story. If you guys have any questions or...
Thank you so much, Dan, for sharing your story. Again, very wonderful to hear you share your insights. I don't know if Professor Negro, you have any comments?
I mean, I'm very interested to hear. I mean, some aspects are very sad, of course. I mean, to know these things too late sometimes. But I would like to underline one word: you're optimistic, and I am very, very optimistic myself. Let me tell you my career, because I mean, my career, not because of career, I'm not talking about that. I'm talking about what I saw in 40 years of working with viral hepatitis. I actually saw everything. Because when I started being a medical doctor in 1982, we did not have anything at all. Actually, even when I was medical student, I mean, the vaccine against hepatitis B was licensed in 81, if I remember correctly, by Natalie, and when it came to Europe, and I was vaccinated myself in 1983. But in those days, I mean, it was absolutely nothing. Most of the pathology we were running was just shaking hands with patients, okay, counseling about alcohol, and that's all. We could not do anything. But now think about what we have seen in 40 years of my career. I mean, I've seen discovering all the viruses, all of them. We can do easy diagnostic assays, very cheap, they cost very little. We have treatments. I mean, treatments for hepatitis C, it was being absolutely a revolution. Now we don't see any new hepatitis C patients on my consultation anymore. Zero. I've been cured everybody. Okay, I have hundreds of patients. I've been treated and cured more than 500 patients in my consultation. And with the new antivirals, not counting with those I cured with the interferon in the past. Hepatitis B, we control hepatitis B in virtually all patients. We have very good, almost perfect drugs for that. We have a very good, I mean, transplantation program everywhere, even in Romania we have it. We have, we have curative treatments for liver cancer if they are detected early, and that's why surveillance is very important. I mean, we can cure, we can burn liver cancer, we can resecate with the surgery, and this end of the story. We don't come anymore. So that's why I'm very optimistic. You are young, you are much younger than me, and I mean, you must be optimistic because God only knows what's going to happen in the next 10 years. And I also encourage you all, guys, to talk about the Clever Center, which allow enrollment in clinical trials, because I see Geneva is participating now to a phase 3 trial with the drug. I will not mention it, but we do have a new, very promising drugs coming out. And we don't have, I agree, we don't have end of follow-up data, but the suppression of viral load is very, very important, very dramatic, and it's very interesting. So we may even think one day about combinations of treatment, the way we do for HIV, for example. So that's why I'm very optimistic and encourage you all to be the same.
Thank you so much. I think that's a good note to leave it on. And yeah, with that, thank you so much to all our speakers for today for an excellent presentation and discussion. We just want to share that a recording of the webinar is going to be available and the slides are also going to be shared. And if you're interested, also, I am dropping some links in the chat for you to join our newsletters. So we have a newsletter for both patients and for providers. So that should be in the chat. And with that, thank you so much
Can I just
for joining
make
today.
a final comment? A final comment can I make?
Yes, of course. Yes,
of course,
please.
I would like to thank you, Ms. Lamini, the Hepatitis B Foundation, for this opportunity. I would like to thank both patients for very inspiring storytelling. I think I've been hearing these stories for all my career, and I always learn a lot from patients. We have a horizon, but you have a horizon.
Absolutely.
That's why we must absolutely to put them together. The last thing, I would like just to be precise about one point. I always mention WHO in my presentation. I mean, the agency which is responsible for classifying hepatitis delta virus is the International Agency for Research on Cancer, which is based on Lyon. And the credit for this classification goes to this agency, which is a WHO agency, but in fact, the whole job was done by IARC, and I really thank them because I was working for them for many years. So I would like to just to be precise on this point, I think it's political, it's very important to recognize what the International Agency for Research on Cancer did.
Yeah,
Thank
absolutely.
you.
Thank you so much for making that clarification too and giving credit to IARC. Okay. Thank you, everyone.
Thank you.
Thank you.
Take care.